All right, hello everyone. This is going to be the first in a series of these type of lectures on the different types of respiratory diseases and sort of the signs and symptoms of them. And we'll also talk a little bit about treatment, that kind of stuff, so that you guys all have an idea of what we're going to be looking at, even in the future, and especially what you're going to be looking at out in the field. So the first one I want to go over is CHF. Now, CHF, I put it into a respiratory category, but CHF really isn't respiratory. CHF is more of a heart problem. It's more of a VQ mismatch problem than it is really a respiratory problem. But because it has a respiratory presentation, I generally will put CHF in my respiratory lecture. So obviously we all know what CHF stands for, congestive heart failure, but and we've gone over the Starling curve and we've gone over the sort of the physiology behind CHF, but I want to go over it again just as a good review. I realize that this is probably old stuff for you at this point, but I want to go over it as a good review. So the problem in CHF is when we have the alveoli, they have been filled with some fluid. And so the problem that we run into is that with that edema, it makes it very hard to get oxygen into the vasculature, right? So this O2 trying to get in has a tough time. Now CO2 has no problem diffusing out. So CO2 will diffuse out without really any problem, whereas O2 will still have a tough time getting past that water barrier. So in congestive heart failure, or the presentation of our patients, what we see most likely is that our patients have a low SpO2 and a normal or high EtCO2. Now, what does EtCO2 stand for? End-tidal CO2, end-tidal carbon dioxide. So their carbon dioxide measurement generally measures pretty normal. Really doesn't measure all that high, but we might see a little bit. We might see a little bit of that they're retaining some of their carbon dioxide. It's always a possibility, but there's always the possibility that we could be without that high CO2, and we could even see a low end-tidal CO2. Now, that seems a little weird because you think, well, wait a minute, you just told me that there's a high CO2, end-tidal CO2. Well, there could be a low end-tidal CO2 as well, and it really just has to do with that VQ mismatch, right? So if on the perfusion side, on that Q side, right, over here, we're having a real problem with getting CO2 to the vasculature and to the sensor, then the sensor is actually going to read that the end-tidal CO2 is low. So the end-tidal CO2 may look low because there's not enough perfusion to get CO2 from the tissues into the respiratory system and then, of course, out and into the air, and ergo making it to the end-tidal CO2 sensor. So there's always that possibility. Well, what way do these patients usually present? Well, usually what we've always kind of classically thought of with our CHF patients is that our CHF patients, they have a presenting with pulmonary edema. And that is true. For the majority of our CHF patients, we see pulmonary edema. And the reason being there is because when we see left-sided heart failure, so left heart failure, that equals pulmonary edema. And that's because that fluid, that blood, gets backed up into the vasculature, and then that pressure pushes some of that interstitial fluid back into the alveoli. And so that's why we see that pulmonary edema. That's why we actually see it. Now, right heart failure, generally when we have right heart failure, let's just put dittos there. When we have right heart failure, what do we normally see? We see a backup into the periphery, so into the body, right? And those are those patients that present with the really puffy legs and they have the pitting edema and those kind of things, right? And that's usually what we see in a right heart failure. Well, take a guess at what the number one cause of right heart failure is. Left heart failure. Right? So when the left side of the heart fails, because there's this constant backup, that essentially is going to cause a right heart failure. So the number one cause of right heart failure is left heart failure. And that's why the classic presentation that we see in our CHF patients is they have both pulmonary edema and edema in the periphery, or peripheral edema, right? So that's why we see that. That's why that happens, because a left heart failure generally is going to create a right-sided heart failure. And most of those CHF patients will start out as being relatively thin people, not having a whole lot of puffiness, not having a whole lot of water retention, and just having a left-sided heart failure. But as time goes on, they'll start to go further and further and further into right heart failure. And so that's why we see that back up in the periphery. So the question is, what are some of the other presentations? Well, let's look at things like what do we normally see, or what do we expect to see for lung sounds in our congestive heart failure patients. When we look at our congestive heart failure patients, when we listen to our congestive heart failure patients, we generally say that we should hear wet lung sounds. Well, here's something interesting about that. Is that I say, and really all I differentiate my lung sounds into is wet and dry. Because the truth is that congestive heart failure can have a multitude of different reasons why this has happened. Maybe that patient has a history of COPD, and that COPD has helped to cause some of that CHF. Well, if that's true, then it's possible that they could have both wet and dry lung sounds at the same time. But the vast majority of our CHF patients, the CHF patient that we expect to see, has that wet lung sound. And they have that wet lung sound because, well, look, they've got fluid in their lungs, and that's why it sounds wet. Now, generally, the sound of this fluid is what I call the very tiny little bubbles. What I think of it as is when you blow bubbles in your water, right? When you blow some bubbles in your water, very gentle, top of the water, you get this sort of crackly sound. And that's what we talk about when we talk about wet lung sounds, is we call them crackles. Now, you've also heard them referred to as either, some people pronounce it rails, and I pronounce it rails, and some people pronounce it rawls. Either way, it doesn't matter. Doesn't matter. Rails, rawls, whatever you want to call it, wet lung sounds, okay? Wet lung sounds, small bubbles, crackly noises. Now, you can have the larger bubbles, which then gives you more of what we call a coarse sound, coarse rails. And that's fine, fine rails, coarse rails, either way. If you're sitting there in the back of the ambulance trying to differentiate and say, is it fine rails or is it coarse rails? You're probably working on the wrong thing. Your patient's probably turning blue and you're like, is it fine rails or is it coarse rails? I don't know. Which one is it? It doesn't really matter. What matters is that we know that this patient is a congestive heart failure patient, and we know then how to treat them. So let's move on to another page here. So, and we'll put it up at the top still, CHF, so that you remember that we're still looking at CHF. All right, so CHF. So some of the other things that we may notice with these patients. We may notice that these patients have a low blood pressure. They may have a low blood pressure. Now, that's not always indicative of CHF because it's indicative of a multitude of other things. And if you learn nothing from these lectures, what I hope that you learn is that you can't just focus on one thing to make a determination that your patient has this or your patient has that. If you're looking simply at the lung sounds and you're saying it's wet, so it's got to be CHF, you're doing it wrong. If you're looking at blood pressure and saying, oh, the blood pressure is low, it's got to be CHF. No, that's not correct either. Because the blood pressure can be low for other reasons. I mean, A congestive heart failure patient could have a normal blood pressure or maybe even a slightly elevated blood pressure. It's always possible. If we're talking about a congestive heart failure patient that is hypervolemic, they've got too much fluid, they could actually have a higher blood pressure. Now, generally what we say, the reason that these CHF patients have a low blood pressure is because they have poor cardiac output. And if you remember, cardiac output is heart rate times stroke volume. And I know you're all sitting at home right now going, okay, yeah, that's enough of that. I've heard enough of the heart rate times stroke volume. I get it, Bill. Well, the problem here in CHF is mainly here. It's mainly with stroke volume. Okay, we have a sick heart, and mainly stroke volume is the issue. They don't have enough stroke volume. They don't have enough ejection fraction. They have too much blood sometimes left over in the heart after contraction. And so that's one of the problems with these CHF patients. So the question then is, what else? What else might we see? So what do you think the heart rate might be? If you're looking at the stroke volume over here, right? You're looking at stroke volume, and you notice that the stroke volume is low, is bad. Well, what does that mean for the heart rate? What's going to happen to the heart rate? Duh. The heart rate's going to have to go up if I want to try to maintain any type of cardiac output, okay? So generally with our CHF patients, our heart rate is elevated. Our heart rate is up. So now the next thing is respiratory rate. Well, you tell me, if you were trying to breathe through water, do you think you're going to have to breathe faster, or do you think you're going to have to breathe slower in order to get that oxygen in? If you're hypoxic, what do you think is going to happen to your respiratory rate? Well, obviously your respiratory rate's going to increase. Now you'll see that with all of the other respiratory diseases, the respiratory rate is elevated. And I think that's kind of a given. If your patient is having trouble breathing, chances are they're going to try to breathe faster in order to get that same oxygen, that same amount of oxygen. They need oxygen, so in order to do that, they're going to breathe faster. Makes sense. Totally makes sense. Heart rate's probably going to be elevated in the vast majority of these. Now, what happens if down the road I notice that the patient's heart rate starts to drop? Well, if their heart rate is dropping and their stroke volume is not changing, this is a patient that's decompensating. This is bad. This patient is decompensating very badly, and they're starting to go down the tube, okay? At this point, if you say, you know what, now I need to treat this patient, that's kind of like now a warning, your patient already needed to be treated, all right? You really needed to treat your patient. I don't know what you were waiting for, but you really needed to treat your patient before that heart rate drops. So get to the patient before this heart rate drops. Don't allow that to happen, okay? And watch for signs that your patient is decompensating. So let's talk about some treatments for CHF. And we've talked about in class, we talked about CPAP. I love CPAP. But remember, there was a problem with CPAP, wasn't there? Now, we said in CHF what we want to do is we want to increase their cardiac output. Well, I told you that CPAP will decrease their cardiac output. Well, that's only partially true, okay? Not that I was lying to you, it's just that I wasn't giving you all the information. You know how it goes, more to come, right? More to come. So what's happening is CPAP will actually increase cardiac output in a patient who is normotensive. It will increase cardiac output in a patient who is normotensive or near normotensive. If the patient is not normotensive, if the patient is hypotensive, then that increase in pressure, right, an excess pressure, will decrease cardiac output. If the patient is normotensive, an increase in pressure, and I know my handwriting is bad, but just deal with it, can increase cardiac output. So if I have a patient who is normotensive and I increase that pressure via CPAP, and that's CPAP pressure. So if I increase that pressure, and they're normotensive or near normotensive, then what I see is I see an increase in cardiac output. And I see that increase in cardiac output because going back to this page back here, what I'm doing is I am pushing some of this fluid. Let me mark where this fluid is, right? So this fluid right here, what I'm doing is I'm now taking that fluid and I'm pushing it up the walls of the alveoli, but also expanding the size of the alveoli. So the original alveoli was this big. I'm now taking and expanding the size of that alveoli, which now means if I don't change the amount of water that's in there or fluid that's in there, right? Now what I've done is I've increased the overall surface area in this alveoli right here that's available for gas exchange. So now I've increased that size, the size of that alveoli. I've increased the surface area that's available for gas exchange. And so now O2 has an easier time actually diffusing because it's got more area to diffuse. So, excuse me. So that's one of the things I'm doing. One of the other things that I'm doing is I'm taking this water that's in here, this interstitial fluid that's in here, and I'm pushing it back into the vasculature where I want it to be. I would prefer that it be in the vasculature. I'm also decreasing the distance between this alveoli. So let's look at this alveoli over here. Let me use a different color here so that you can see it better. I'm decreasing the overall distance between this alveoli over here, the alveoli on the upper left. I'm decreasing the distance between that alveoli and that vasculature. And so now with all of this edema that was in here, I had a bunch of edema in here. Because I'm decreasing that edema, I'm now decreasing the physical distance between those two areas that are needed to do good gas exchange, right? So that's the reason that I put CPAP on those people. And I know it seems a little weird when I say, yeah, if I put CPAP on, I could create VQ mismatch and decrease cardiac output. Well, that's true in my hypotensive patients. If their Starling curve is already bad, if their Starling curve is already kind of flat, well, if the Starling curve looks like that, if their Starling curve is really flat, then it really doesn't matter. I mean, the amount of pressure that I put on this, as I increase the pressure, I'm going to take that Starling curve, I'm going to drive it downward and backward. And that means less cardiac output. That's lower cardiac output, okay? So, we said in CHF, we like CPAP. Well, what else do we like to use in patients that have CHF? Some people like to use albuterol and Atrovent. Now, for me, that comes with a caveat. We don't just use albuterol and Atrovent on every CHF patient. That is a problem. If you're giving albuterol Atrovent to every single CHF patient, there's the possibility that you're increasing myocardial oxygen demand, right? So increase O2 demand in the heart. You're increasing the O2 demand in the heart. If you increase the O2 demand in a heart that's already sick, you're just going to make that heart sicker. So the only time that I recommend using albuterol and Atrovent in a congestive heart failure patient is when I notice this on their end-tidal CO2. And everybody knows what that is, right? You've probably heard of it or seen it before or heard about it at least. It's called shark finning, okay? So if I have a CHF patient that I notice that there's some shark finning on their end-tidal CO2, well, then I think albuterol and Atrovent, well, that's a fine idea. That is a fine idea. Even the Atrovent, I may hold on the Atrovent, right? I may say, okay, I'm not going to give Atrovent. I'm just going to give the albuterol, and that's fine. You can do that if you want. Just give the albuterol and see if you can relieve this bronchospasm. And that's what this is. This is bronchospasm. That's bronchospasm. So if I can alleviate that bronchospasm by giving albuterol, which is a beta 2, well, that's a great idea. That's perfectly fine. I'll alleviate that as much as I can, and that'll help. But in the vast majority of my congestive heart failure patients, what I instead see for their end-tidal CO2 is more of a boxy formation like this, right? Their end-tidal CO2 looks a little boxed off, and they're actually, they're not really bronchospasm. Well, if they're not bronchospasm, then why am I giving a bronchodilator? What's the point? If there's no bronchospasm, right? So let's go to red and say, whoop, no bronchospasm, it's not there. Then why a bronchodilator? Why? There is no reason. There is no reason. So if I happen to see that my patient who's in congestive heart failure is not showing signs of bronchospasm, then I avoid bronchodilator. There's no reason to do that. And instead, I go for things that will increase cardiac output, right? That's my goal. If I can increase cardiac output, that's great. That's awesome. Now, there are ways to increase cardiac output. So let's talk about a way to increase cardiac output. Well, the first one is heart rate, right? So heart rate. So some of you may say, well, if I want to increase heart rate, epi's a good way to do it. Avoid that. Avoid epi. And the reason that I say avoid epi is because the problem with epi is that I will increase heart rate to a point, and I will also vasoconstrict, right? Because I will increase heart rate with epi, but I will also vasoconstrict. And you think, well, that's not bad. I'm increasing the blood pressure. No. Bad idea. Bad idea. That's not the way we want to increase the blood pressure. What we're doing in doing that is we're increasing the heart rate, which means we increase the demand for oxygen, right? The heart wants more oxygen. And then we vasoconstrict. Uh-oh. And we decrease the amount of oxygen that could potentially go to the heart. So now I'm making the heart work harder and giving it less O2. Yeah, that's a bad idea. That's a really bad idea. Your better choice, if you really want to increase heart rate, you're not even really increasing. Well, you will get some increase in heart rate, but mainly what you're going to get is you're going to get an increase in inotropy, and the answer is, you probably already know by now, dopamine. Dopamine is your better choice here. Dopamine is your better choice. Now, there's a benefit. There's a couple of benefits to giving dopamine, but one of the really cool benefits of giving dopamine is that I get some renal work. And if the renal system will start to function a little bit better for me, that's great. That's great, because I may be able to get some of that fluid off of the body. And the good thing about it, rather than using a diuretic like a Lasix, is it goes a little slower. It's a little slower, it takes a little bit more time, and there's a little bit more saving of potassium. So let's go to page 4 here and talk about Lasix, CHF. Lasix. Dun, 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 Lasix. Yeah, I know Bill said don't use a Lasix. Well, it's more nuanced than that, okay? You will never really hear me talk in terms of the do and the don't, right? You know that. You ask me a question, what happens? Bill sits there and ponders it for a little while and then gives you the longest answer you ever expected, and all you wanted was a friggin' yes or a friggin' no. Thanks, Bill. Anyway, Lasix. Well, so here's the thing, okay? If I am giving a lower dose of Lasix, sort of like a 40 milligrams of Lasix, chances are I'm probably not going to hurt my patient all that much with 40 milligrams of Lasix, okay? The problem with Lasix is really this guy right here, potassium. I lose potassium when I give a patient Lasix. Now, if I had something on the truck that I could give them that would save potassium but get rid of some of that fluid, well, okay, that might be helpful. Well, that's where I go back to dopamine, because I say dopamine can do that. Dopamine can do that. Now, you will lose some potassium with dopamine, there's no doubt about it, but dopamine can definitely help to save some potassium while at the same time getting some of that fluid off. And even better with dopamine is I'm increasing cardiac contractility, right? So I'm seeing a better squeeze out of the heart. And again, he's going to do it again, isn't he? Don't do it, Bill. Don't do it. He's going to do it. Yeah, he's going to do it. He's going to write that friggin' thing again. Oh my God, I'm going to kill him. Heart rate times stroke volume. So with dopamine, if I'm increasing stroke volume, awesome, right? And that can definitely help. We already talked about the heart rate issue when it comes to epinephrine. Not necessarily the best idea because now I increase myocardial oxygen demand as well. So stroke volume in dopamine, that's the goal. Lasix, maybe, again, if I'm given 40 milligrams of it, okay, maybe I could go with that. But to be completely honest with you, you'll see Lasix is going away. Lasix is really going away. And the reason that Lasix is going away is not just because of this guy right here, potassium, although that's a huge deal. It's not just because of potassium. It's also because it dehydrates. So it dehydrates the patient. So then what's the answer for the dehydration? Well, let's give them fluid. That's a brilliant idea. In a congestive heart failure patient, you're going to give them fluid when they already have the potential of fluid overloading because they can't get the fluid around the body where it's supposed to freaking be. So, yeah, that's the problem I really have with Lasix. The other thing is that I really cannot be 100% sure that my CHF patient, and some people will disagree with me on this, but that my CHF patient is, in fact, hypervolemic. I can't be 100% sure. Not 100%. Now, the way I can be sure is if I draw some blood and I look at things like serum lactate or BNP and those kind of things, and I might be able to really tell if my patient is in fact dehydrated or if they're not, if they're hypervolemic or well, I shouldn't say hypovolemic. I mean, we can kind of tell, but to tell whether or not my patient truly is flooded with fluid, I really have to look at things like I said, like a BNP, right? So I can look at their BNP, I could look at a lactate. And that's more for a critical care medic, but you know, if I wanted to look at those things, that I might be able to determine whether or not my patient truly is hypervolemic or dehydrated. Okay, so I can't do that right now. That's the problem. I can't do that. I don't have the ability to draw those labs out in the field. And my way of looking at it is if I can't tell for sure, then the treatment as far as Lasix goes either needs to be non-existent or needs to be in a very low dose. And I would even say 40 milligrams, maybe I'm not going to go there. That might be okay. Again, might be okay. But maybe I'd go with something like a 20 milligram dose. Okay? So I could even go lower. Now, they give Lasix to patients that have congestive heart failure. The doctors do it. And again, that's all fine. But they have the monitoring equipment to then keep an eye on what that patient is doing, what the actual fluid retention is in that patient. And since we don't have that, and in the field, really, to be completely honest, Lasix, it's effective. It is effective. You'll get your patient to pee. But the problem is that I just create so many problems for the patient down the line. So my answer is CPAP. Now, I haven't mentioned nitro yet, have I? Yeah, so why nitroglycerin? Why do you think nitro could be a choice there? Why CPAP and nitro? Think about that for a second. All right, time's up. Well, if I want to push fluid back into the vasculature, if I want to make the heart more effective as a pump, then what I want to do is I want to open up the vasculature so that I can get that fluid pushed back in the vasculature. It's much easier to push fluid into a vessel of this size over here than it is to push fluid into a vessel of that size over there. Okay, so that's why nitro. Got to give the fluid a place to go. So I'm going to push the fluid back like that. Now you would say, well, wait a minute. Nitro drops blood pressure. Oh yeah, I agree. Nitroglycerin drops blood pressure. That's why you have to monitor your patient. Monitor your patient. Watch them. Question is, how much nitro do I give? Well, There is no answer to that, right? There is no answer to that. You're a medic now, right? In the old days, it was 3 nitros and then no more. That's it. Well, we don't do that anymore. We're medics now. So we give enough nitroglycerin to get the desired effect and to not drop the blood pressure precipitously. There you go. There's your answer. Yeah, I know. Frustrating. I get it. But that truly is the answer. The answer to this is give enough nitroglycerin to get the desired effect without dropping the patient's blood pressure. Okay? Why? Why did that whole 3 nitros and that's it thing arise? Well, it arose because doctors used to tell their patients, and they still do, if you take 3 nitroglycerins, you need to call EMS. Okay, well, EMS said, well, that's where we're going to stop then, is at 3 nitros. Well, that's good for basics and that's good for advanced. But when it comes to paramedics, you have a completely different world. Okay? Now, of course, it's always protocol dependent, but it's a completely different world out there for paramedics. We get to do what is really, honestly, truly best for our patients, and that's what really makes us practitioners rather than just technicians. Okay? So there you go. That's what I've got on CHF. So our CPAP, our nitro, our dopamine, and we may talk about a few other things later on, maybe in the face-to-face lecture, because you may have some questions about, well, what about this medication or what about that medication? Are there other ideas that we can use? Yes, possibly, but I will talk about those more when it comes to cardiology, because now we'll actually be talking about cardiac function rather than just sort of a basic idea of what to do about a CHF patient who presents with a respiratory illness. So that is my lecture. I hope you enjoyed it.